Good afternoon. Welcome to the Bessie Smith Culture Center, and welcome to our second series on minority health and health equity. Tonight, we have some young ladies that are physicians here in the city of Chattanooga that we're so proud to have here. We'll be talking about neonatal care, maternal care, and infant health care. We'll be talking about all those kind of things. So we hope that you will get a little bit out of this. You can always contact these physicians once this series is over, or once this panel discussion is over. And you can also go to our YouTube channel, the Bessie Smith YouTube channel, after tonight and pull it back up also. Dr. Jacqueline Shaw will be our moderator tonight. She's with Pediatric Healthcare out on Wilcox Boulevard. So we hope that you all will use the services of all of these physicians, and they will tell you about their practices in their introduction. Thank you again for being here. Hopefully you will get something out of this. Look forward to having you again when we do our next series. Thank you again. Oh, and for questions, we will have questions after the physicians finish with their dialogue. Thank you.
Thank you, Eli, and welcome everyone. We certainly appreciate your attendance this evening. Again, my name is Jackie Shaw. I'm a pediatrician. I've been here for several years, and I call this home. I love that introduction that Eli said, a panel of young women, so I'm going to take that and run with it. This is our second series. We're going to be talking about disparities in maternal and health issues. These young ladies, and I'm going to introduce them from my left, we're going to start talking about maternal issues and the disparities that we have there, and then we are going to be talking about the infant with our neonatologist and then our pediatrician. To my left, we have Dr. Yolanda Spraggins. She's a pediatrician, and she is with Galen Medical Group. Next to her, we have Dr. Portia Adams, and she is in her last year of her OB residency, her fourth year, and we are just really excited for her. And she's, I hope, going to stay here in Chattanooga. Next to her is Dr. Shavonda Shiro. She is a practicing OBGYN. Her clinic is called Innovative Women's Health Specialist. She's been here a number of years. I'm not going to try and guess the number because I may give her too few or too many. But she has been a staple in our OB community. Next to her is Dr. Spencer. She is one of the neonatologists here at T.C. Thompson Erlanger Medical Center. And next to her is Dr. Stephanie Holt, and she is also a neonatologist. Now, what we've asked our panelists to do is to give some general information for about 10 or 15 minutes within their specialties, answer some questions about disparities that we have in those areas, and then at the very end, we're going to open up the floor to questions that you may have. So if you want to jot something down, or if you can keep it up here, I have to write things down now. These young women have to write things down. But we're going to entertain questions from the audience and questions from live stream. So we'll first start with Dr. Shiro and Dr. Adams, our OBGYN. Dr.
And like she said, I'm in my last year of residency. I've been training for the past 4 years at Erlanger Hospital. I grew up here in Chattanooga, so I'm really glad to be back here training. And yes, I plan to stay in town and practice. And I'm really glad to be here tonight and glad that everyone is here with us. Just to start, I think it's really important that we acknowledge some of those things that can negatively affect minority women and minority moms. One of the leading causes of adverse outcomes is due to cardiovascular health. And so things surrounding, blood pressure and preeclampsia and diabetes and heart disease and those types of things that moms have prior to pregnancy and then going into pregnancy. And that's something that I've been really passionate about. And so if we have questions regarding that and things to look for in that regard, I know one of the things we kind of talked about too initially was just in general in Chattanooga, where do you get OB care versus, gynecological care for other, issues that affect women. As far as delivering at Erlanger Hospital, Erlanger East Hospital, and then Park Ridge East Hospital. Locally, those are the hospitals that can take care of moms and babies. And then in addition to that, Memorial Hospital, Memorial North Park, Park Ridge, Maine, those hospitals where they take care of women as far as GYN issues also. So that's kind of just to start. If you want to.
Hi, I'm Dr. Siobhan DeShiro. I practice at Innovative Women's Health Specialist. I've been here since 2011, so I'm a transplant, but now I'm rooted strongly in Chattanooga. I'm very passionate about everything OB/GYN, especially, I'm OB/GYN, so women's health care is number one, but I think the biggest disparities for minorities is one, we start off as women. Women need to be great advocates for their health care. Usually we're advocates for everyone else's health care in the household. We don't take care of ourselves. We make sure everybody else is taken care of. So that leads to some of the disparities that we were talking about, Dr. Adams was talking about with blood pressure issues. The biggest thing that kills a lot of minority women and that's African Americans and Hispanic Americans, 3 times more than white Americans in the United States, and very high, very disproportionately high in Hamilton County and Shelby County too. In Tennessee, we're number 8th and 9th in the country as far as mortality rate for minority women in the country. So that's something to keep in mind. But when you go and you have your primary care doctor, which I know most people don't have a primary care doctor. They try to use their gynecologist as their primary care doctor. Everybody, the one thing I would say is get yourself a primary care doctor. Go to your primary care doctor every year. Gynecologists were great with triage and we're great with maternal physiology and different women issues, but you still need a sentinel person that's looking at your general health. So they're checking your cholesterol, they're checking your blood pressure. So when you come into pregnancy, you are ready at where you need to be so that you can have a healthy outcome. The other thing that we see a lot is our general nutrition is less than what it should be. Just our regular vitamins. Vitamin D is we're severely deficient in, that helps with our muscle functioning, that helps with healthy pregnancy, cardiovascular issues. So just your baseline nutrition is something that we see that is an issue along all minority groups within the United States, along with, I think, institutional biases for minority women in general. So the biggest thing I could say is make sure that you advocate, not just on TikTok or Facebook or Instagram or what someone said at the hairdresser, but actually partner with your provider. Don't be as mistrustful thinking that they're not looking out at you for your best interest. Find that person that you click with, listen to them, and become a partner and have them explain things to you so that you can understand and back that up outside of just what you get randomly from other people's advice.
Hello, my name is Dr. Stephanie Holt. I'm originally from Nashville, so I've lived in Tennessee. I have been in Chattanooga for almost 4 years. I've been a neonatologist for almost 7 years. Kind of one thing that we'll touch on is infant mortality, which is in part kind of tied to maternal health. When you talk about infant mortality, it's a death of an infant that happens before their first birthday. And to put things in context, in 2020, the rate is about for every 1,000 infants born, about 5.5 died in 2020. But if you look at African Americans, that rate was like doubled. So 10 African American babies died for every 1,000 born. The most common causes, some things we can't control, such as birth defects, but there are some other things that we can try to prevent, such as preterm birth, sudden infant death syndrome, which has there are some recommendations that can prevent those deaths. To put in context, in Tennessee, in 2020, 115 babies died of sleep-related events, and about a quarter of those were probably preventable, and it's still the fourth leading cause of death in infants. And there are things that we can actually teach parents that can help to prevent those deaths. And then going in, the other causes are maternal pregnancy complications Dr. Shiro talked about. Mother's health is greatly tied to how infants do. So just making sure that mothers get the care that they need just to try to prevent some of these decreased infant mortality rates.
Good evening, everyone. I am Dr. Michelle Spencer. I'm one of the neonatologists at Erlanger Children's Hospital, and Dr. Stephanie Holt and I are two of the first Black neonatologists in that unit, so we're happy to serve our community. There are some things that we'll go over, and I usually like to give some hope, even though we're talking about infant and maternal mortality, which is something that if we could snap our finger and change, we all would, but we're not able to. So understanding that it exists, we want to know how can we navigate it so we can make sure that we are as safe as we can when we have to experience different conditions that cause us to have to be in different healthcare settings. I read a Washington Post article that said the United States is the most dangerous of wealthy nations for a child to be born into. This was based on a January 2018 report published in Health Affairs that sounded alarm bells about the country's high infant mortality rate. U.S. babies they found were 3 times as likely to die of preterm birth and 2.3 times as likely to die of sudden infant death syndrome, which is SIDS. And that's compared to other rich countries. As Dr. Holt stated, infant mortality is defined as death during the first year of life. 66% of those deaths for all races occur in the neonatal period, which is the first 28 days of life. 14% of those occur in the first hour of life, and 26% of those occur in the first 23 hours of life. So as doctors that work in the NICU, taking care of the sickest babies, Dr. Holt and I see a disproportionate amount of infant deaths. What is the NICU? Some of you have had the privilege of never having to experience the NICU. The Neonatal Intensive Care Unit, NICU, is the ICU for babies, usually newborns, in the NICU. We take care of babies that are premature or even term babies that are born very, very sick. A premature baby is a baby that's born before 37 weeks. In the NICU, advances in medicine even allow for resuscitation of babies as young as 22 weeks gestation, but these babies are considered extremely premature. The more premature a baby is, the higher risk of infant death, and the more likely that the baby that does survive will be affected by severe prematurity-related medical conditions. This can include, but is not limited to, chronic lung disease, significant developmental delay, cognitive impairment, and even cerebral palsy. This is why the information that is shared with regards to maternal health is so important. And prenatal care is one of the most important things that you can do to create a great, the best outcome for your baby. So the National Birth Equity Collaborative stated that the health of babies, even before conception, can be improved by addressing the needs of Black mothers and creating programs that improve prenatal care and provide timely interventions to alter the course of health of Black babies and their mothers. So I just wanted to do a basic orientation to the NICU, just basic, just in case you have to come to the NICU. Dr. Holt and I recognize that when we see patients in the NICU, it's not because they've chosen us, like Dr. Schroe, Dr. Adams, Dr. Spraggins, or Dr. Shaw. They don't choose us. If people could avoid coming to our area of the hospital, they would, and I totally understand that. So when I interact with parents in the NICU, I recognize it as a traumatic experience, and we provide tenderness in the care that we're given to even the parents, not just the babies. So in the NICU, babies are taken care of by healthcare providers that are specially trained for taking care of critically ill infants. The NICU team includes a NICU doctor, so a neonatologist like us, neonatal nurse practitioner, NICU nurses, NICU pharmacists, respiratory therapists, occupational and physical therapists, social workers, audiologists, and lactation specialists. In every NICU, there is a time during the day when the NICU team rounds at the bedside and discusses the infant's clinical status for the past 24 hours and the plan of care. Parents are encouraged to participate during rounds as a valued part of the care team. Visitation for parents in most NICUs is 24/7, so in most places. You think of babies and you just think of innocence, right? So a lot of times in society, we want to protect the baby. Some people refer to our patients as tiny humans. You know, they're not really tiny humans, but they are small, you know, a little bit different in physiology. But so does healthcare disparities affect our babies in the NICU as well? Unfortunately, it does. So as mentioned earlier, the U.S. has a very high infant mortality rate when you compare it to other high-income countries. And that mortality rate, as Dr. Holt stated, is that high. That's 5.4 deaths per 1,000 live births, and Black babies have the gravest danger. The infant mortality rate for 2020 was double that of the general population for other babies, so it was 10.4 deaths per 1,000 live births, comparison to white babies where it's 4.4 per 1,000 live births. And like I mentioned earlier, for the US, it's 5.4 for all babies per 1,000 live births, and that's in comparison to Norway that has 1.6 per 1,000 live births, just so you have a point of reference. So US is one of the highest at 5.6, and Norway is one of the lowest at 1.6. The top 5 causes of death are low birth weight, congenital malformations, sudden infant death syndrome, which was mentioned, accidents, so that's unintentional injury, and maternal complications. Some of the disparity in Black infant mortality can be attributed to the higher rates of premature births and low birth weight among Black infants. Low birth weight being a weight of less than 5.8 pounds, and very low birth weight being a weight less than 3.4 pounds or so. However, complex racial and/or ethnic disparities in structure, process, and outcome measure often disadvantage infants of color, especially African American infants. But there's hope. So I did say, you know, we can't change at the blink of an eye the current circumstances of that are experienced nationally with an increase in infant and maternal mortality, but we can learn how to navigate the system. So what is the best advice that I would give a parent on how to advocate for their infant while in the NICU? Be present as much as you can. So good visibility, where people are seeing you is really important, and it also has a great side effect that you being present for the baby also helps for their development, so it's twofold. And then whenever possible, try to be present during rounds, so that's very important. So each NICU has a time when the doctors and the nurses will round together, so if you can be present during those times, that's really good for you to be able to ask questions of the team when they're creating the care plan for your child. If you're unable to visit daily, which we understand, lots of parents have other things, they have to work, they have other kids, so we recognize the pull in multiple directions for parents in the NICU. Call often for updates. The nurses usually provide updates on the clinical status of infants, and we usually update the nurses during rounds, so they are up to date with the minute by minute, really, of what's going on with your baby, so they're a great resource. If you're unable to visit the NICU daily or you only visit at night, then you can also ask to speak to one of the doctors, so the neonatologist or the nurse practitioner. So you might not automatically get a call for that, but if you request it, it will occur. So those are some things that people don't realize. So you could think, I didn't see the doctor, so that's the end of it. But if you ask, can I have the doctor call me so I can get an update on my baby, they'll definitely give you a call. The other things that I like people to know that they might not otherwise be aware of is you can request a core team of nurses to take care of your baby at our NICU. It's optional to the nurses whether they want to be a part of the primary care team, but you can request it. And having a core team of nurses is of benefit to the baby. So that's something a lot of people don't know that they can ask, but you can ask. And then the last thing is if your baby's medically complexed or critically ill, then you can ask for a care conference. So a lot of times, especially on TV, you can see doctors sitting down with patients and families when something gravely, like the patient's gravely ill or somebody's dying. But you can also have this to formulate a plan to direct care, even if the baby is not in a state where they're very critical. So you can request that, and that is also really helpful. And yeah, I think that's some of the main stuff.
Good evening. Again, I'm Dr. Yolanda Spraggins Wilson, and I'm a pediatrician in private practice with the Galen Group. I have been here a good while. I had in my mind one thing I was going to say, but I think I will start to kind of reiterate some things Dr. Chereau said, that the best start you can give your baby is to take care of yourself and to provide the best environment you can. Everyone has different circumstances, but I think that if you can be the best person you can be, that goes probably the most with giving your child a good start. If you can do that, not that you can always relieve your life stress, but to be mindful that you have to put your oxygen mask on first. Otherwise, you're working on fumes, and that's what your child will get, kind of some leftovers. And so you have to be mindful of that. I think probably one of the most things that are important is to read to your child, talk to your child. Don't necessarily let YouTube or Gracie's Corner, and not that those things are bad, or Coco Melon babysit them, but read and talk to your child. Even if they're in the room flipping, like my child would flip in the book and throw it, but you still get the book and still read them, because even though they're doing flips and tearing the room up, they can still process and understand if they won't sit and read with you. Try to be intentional about nutrition. Now, I know children are hard. When they decide they don't like something, they will not eat it. But if you can avoid giving them a lot of processed food, and people say, oh, it's just easier to buy fast food, but actually it's just as easy to pick healthier choices. Even from McDonald's, you can find some healthier choices. To be intentional about nutrition, and also sleep. Children need sleep, and they need a good sleep schedule. And so everybody needs sleep. And so if you can focus on their mental development, their nutrition, and their sleep, everybody will be much happier. And for babies, it's still safest, I do want to back that up, alone, back, and in their own space. And to know that some babies are tummy sleepers, they just are, but it is still safest for them to sleep on their back. Even if they have reflux, they still need to sleep on their back. Those are some of the main things. As far as a parent, you are, of course, your child's biggest advocate. And so do not be afraid to come with a list to your doctor. And if something is not clear, don't go home in a fog. Either call them back or message them so that you can get clarity about the best plan for your child. And if you have a child with complex needs, one of the jobs that I serve is to kind of be a care coordinator, that you want to make sure that they're having regular hearing screens. If you have a baby that came from the NICU, that they're having regular vision screens. Try your best to make every appointment. And if you need help, there are lots of community resources actually to help you. Even if you have insurance, people who have Medicaid can have help with transportation and a lot of different things, but you can also find some programs that will help working parents who may not have those extra benefits, or parents who are the kind of in the middle. I call the working kind of poor, who don't qualify for extra services but also don't have extra money to spend on certain things, gas back and forth to different appointments. There are some programs in the community that can help you, and so your doctor may be able to help you navigate those things and get the extra help you need for your child. But make sure you get all the immunizations, but I feel like all children should have the COVID vaccine, but especially if you have a child who has high needs, who has any respiratory problems, they need to have it, and you need to have it as well. The vaccine is safe, and it's better than COVID, to getting COVID. And every immunization, and get them on schedule, that those things are very important, and that you are up to date on your immunization as well. And to be careful about the environments as far as smoke. I would not try to have a smoke-free home, and that doesn't mean smoking in a room with the window up. That means outside if you are going to smoke, and no smoking in the car. Those things, babies who are exposed to smoke have higher incidences of respiratory illnesses and higher rates of SIDS. And even third-hand smoke is not good. That means in your clothes, in your drapes, in your carpets, your rugs, your couches. So it's best if you not smoke, but if you do, outside with the coat on and a hat on, so that you're not coming back in still exposing your child to smoke. Trust your doctor, partner with your doctor, and I think most pediatricians, I feel like in our community are good and are concerned and care about their patients, and not just about making money, or that they really care about the children. And so partner with your doctor, and not Dr. Google, Dr. Facebook, and even grandmama. Not that grandmama is always wrong, but listen to your doctor, that they have experience, they know, and hopefully you'll build a good trust and relationship with your primary care doctor, that you will be able to trust them and trust their advice. And then most people are amenable, if you disagree, that you can talk through it and make a plan for your child to get the best care for your child, because that's all that all of us want to do, is to take the best care of our patients and empower them to take care of themselves. I'm talking now. Keep going.
That's really been some great discussion, and I'm sure that we have some questions that are going to come online, but there are lots of questions I've just been writing, and I'm going to take the liberty to ask some of the questions that I think may be on our audience or online. One of the things that our OBs said was they were talking about preeclampsia, and I really do think that we need to delve a little bit further and tell us what preeclampsia is, if you don't mind.
So preeclampsia is a condition within pregnancy where you have elevated blood pressures, and it's also a condition, if you get into the nitty-gritty, your kidney functions are not exactly where they need to be, and you can be spilling protein into your urine and different things like that. So it's something that you should have your blood pressure checked at every OB visit that you go to. We also look at your urine to look for that protein, and then we look for some other kind of signs and symptoms of preeclampsia. As you get further along, some of those things, we're looking at, are you having headaches? Are you having shortness of breath? Are you having chest pain? Are you having right upper quadrant pain because you have some dysfunction going on within the liver? So those are some of the signs and symptoms that we look for, or things that you would hear your OB doctor or your midwife or your family doctor asking you about throughout the pregnancy. within that condition, if your blood pressures are not controlled, you can have a seizure, and so that's one of the big adverse outcomes. It can prompt early delivery, depending on if blood pressures aren't controlled properly, or if we're seeing, when we're doing, antenatal testing and looking at testing for baby, if we're seeing some adverse outcomes as far as if the baby is not getting everything it needs from a placenta standpoint, because within that condition, the placenta is just not doing its job very well. And so it's something that we always look for, always screen for, always ask, and it is something that negatively, it affects more African American women and Hispanic women in pregnancy.
Usually the reason we see more preeclampsia in African Americans and Hispanic population is because we have a predisposition to hypertension anyway, so we have high blood pressure. So if you have high blood pressure or family history of high blood pressure, you're more likely to develop preeclampsia in pregnancy. So if you have high blood pressure, the biggest thing you can do is get your blood pressure under control before you become pregnant. If you've had a history of preeclampsia before, is to get early prenatal care. And there's a few studies that show that starting a baby aspirin, 81 milligrams daily, usually starting that after 12 weeks or before 16 weeks, helps delay the worst parts of preeclampsia. Because preeclampsia is one of those things, when it starts, it doesn't stop until you're delivered. And the other thing about preeclampsia, the big key factors that lead to mortality in minority women is preeclampsia doesn't necessarily end just because you're delivered. Preeclampsia can persist up to 6 weeks or more after delivery. So you can be delivered, your blood pressures can go back down, you're peeing good, you see your toes again, you think you're okay, and you think you may just have a headache because you're tired, you're up with the baby, you haven't been eating well, but really it's starting to be those signs of preeclampsia again, and your blood pressure is elevated and your body's just been used to having high blood pressure. So if you don't go back to your doctor or get checked out, what can happen with not just a seizure, you can have a stroke, you can have temporary blindness. But the other thing that you can have is unattended high blood pressure can lead to your heart working overtime, and we get into something where we have heart failure. And that's really common in African American women. We have heart failure, we don't look back into it, and then we have sudden death. They're found dead in the home or at work or in some transit where they were taking care of their baby. The other thing we get back to is nutrition. The other thing that you can do to help prevent that besides that baby aspirin is something called CoQ10. It's a multivitamin that you can take. It's over the counter. You don't have to make it at home or anything. You can take that. That helps naturally lower your blood pressure. I'm sure everybody's heard about how the benefits of garlic, but it's similar to that. The other thing that you can do to help with the risk of high blood pressure is omega-3 fatty acids, the fish oil. It naturally lowers all the bad fats that are in your blood vessels, so you have less risk of having stroke, and also lessens the placenta's effect. So if you imagine with high blood pressure, the placenta is a filter, and the filter is just getting clogged. So imagine you're changing your filter at home. It's just you need to clean it, wash it out, keep it clean. The best way to do that, in the house we vacuum so the filter doesn't get dirty. So the omega-3 fatty acid can help be your vacuum so that the placenta is not getting clogged, so the baby grows well, and you have less chance of early preterm delivery or problems with the fetal growth.
One of the phrases that I've heard all of the panel members talk about is advocating for ourselves, being an advocate for our health. Just as an aside, and I've got to say it because I was listening, recently, yesterday, I had a patient in the office, and this mom had a newborn baby. and we were talking about her pregnancy and her delivery, and we were asking her if she had been on any meds, and she said that she had a delivery, but her blood pressure was up, and her blood pressure had been up for about a month prior to her delivering. And so she went in, and she was kind of puzzled about it, and the long story short was this mom knew something was going on and was kind of concerned about why her blood pressure had not been addressed. And my response to her was, you've got to advocate for yourself. And so that's something that we have heard in all of the specialties, OB, neonatology, and pediatrics. We don't necessarily like to have Dr. Google. And I have this little cup that talks about Google and being a doctor. But we've got to make sure that our parents and our patients are advocating for their needs. Another question, I don't know if we have any. Do we have some? Okay, great. The first question is, I have gestational diabetes. What can I do to be sure my baby is born healthy aside from eating healthy?
So I still think the number one thing, of course, is attending all of your OB visits and following up with your provider. Sometimes, depending on the level or what blood sugars look like, sometimes we send patients to a high-risk doctor or maternal fetal medicine. We have a group that's in town, and that's another area where you want to ensure that patients are going to those visits and not missing those visits. One of the things they do specifically for gestational diabetes, whether it's with the high-risk group or with your primary care doctor or your OB doctor, is making sure you're documenting what your blood sugars are, and so making sure that if we ask for documentation that you're able to provide that. And then, of course, lifestyle modifications are always going to be a really big thing. Outside of pregnancy, like Dr. Shiro had hinted at, doing those things before pregnancy, but then also within pregnancy, even if it's just starting out 15, 20 minutes, 30 minutes a day walking, is the best way to start if you weren't already physically active prior to pregnancy. So those are the two big things. Of course, watching what you're eating, and then also lifestyle modifications.
Dr. Shaw, we were just going to tell them what it would look like for the baby if the mom has gestational diabetes, just what are some of the complications that we can see. So I really like that question. It helps us to see that you, like a lot of mothers, have a lot of love and care for your baby even now. So for us, we usually see if there are some complications, the baby could require an ICU admission for low blood sugars.
And also, they can be born larger for their age, but they can also be born smaller for their age, and there can be complications related to that, such as sometimes a difficult vaginal delivery if they're called large for gestational age. If they're small, there can be issues with temperature regulation, feeding, and so that can, and low blood sugars, which can require a NICU hospitalization.
There are some times when diabetes can affect the babies in terms of how they're formed. So sometimes we will actually check to make sure that the baby doesn't have what we call congenital heart disease, which means an abnormality of how their heart was formed. So we would assess that. But it's a very high likelihood that the baby will do very well. And I agree with what Dr. Adams said. Follow up closely with your obstetricians and efforts are made at our hospital. Even if babies do have low blood sugar, we try our best to keep the baby with the mom out of the NICU. So we try to keep you together, even so much so that we use something now called glucose gel, which will help to raise the baby's blood sugar without the baby needing an IV. So those are all efforts that we do to try to make sure we don't have separation between the mom and the baby. But if the baby does have to come to the ICU at any one of our hospitals in the city that have an ICU, they'll be in good hands, but at least you know some of the things that we watch out for. And a lot of the parents wonder what's the big deal with hypoglycemia. The blood sugars drop a little low, it'll come back up. But the reason why we're so focused on making sure blood sugars stay in a normal range is because the brain uses blood sugar as its main source of energy. And for babies, their brains are developing quite rapidly, so we want to make sure that it has enough energy for their brains to grow appropriately.
I have a question for Dr. Wilson's Spraggins. Spraggins, I'm sorry. I have a little niece that she just turned 2, and she's already taking breathing treatments for asthma. And her parents don't seem to understand. Well, they might understand, but to me, they're not taking it as serious as they should. So what are some of the things that they should be doing in order to make sure that she's in the right zone? She's been taking breathing treatments for a year now, or more than a year. And like I said, she just turned 2, and she's already.
Well, it may be quite a few factors. If she's in daycare, it may be that for most younger children, if they need breathing treatments, and we don't necessarily call it asthma, but we treat them like it's asthma. And a lot of it, most of the time, is caused by respiratory infections. But I guess if there's a child who would have repeated infections, usually I would start them on a preventive medicine. And so I don't know if she is on just the rescue medicine or if she's on a preventive medicine. And so you may talk to them about that, especially if every month she is needing a course of breathing treatments. That they may, talk to their doctor about that if she needs to see the allergy asthma doctor, or if she needs like a more preventive medicine to help as well. And this season has been hard because of the isolation of most younger children during COVID. They just weren't exposed to the normal amount of respiratory infections. So this year, I think they've had every virus known to man, like every week is something different. And so that's been some of it, that the kids have stayed sick for that reason, and that, we're not taking pretty much any precautions. And I don't know that people are even cleaning surfaces like they should be still. Well, that puts her at higher risk. If you have family history of those illnesses, if she's had eczema, that would put her in a higher, and more risk for eczema.
Yes, she's had eczema, and like I said, I just said asthma because we've had at least one kid to die from an asthmatic attack. So I just wondered if.
And I don't know, since, sometimes they, especially if they're younger parents, and not to have any specific advice against, but you don't always like people telling you what to do about your child. And so that you may mention that to them, that if she is only taking a rescue medicine, to talk to their doctor about maybe, because I'm sure they're not happy that she is sick all the time and that she's having trouble breathing all the time, because that can be pretty scary. When your child is having trouble breathing. And so you may, if she's not on a maintenance medicine, or since she has the family history and has eczema, she would be more likely to really have asthma. And so then maybe talk to them about getting a referral to an allergy or asthma doctor.
Hey, good evening. There have been a few disparities mentioned during the panel, such as, I believe, lack of attending regular healthcare appointments, as well as what was the other one? My goodness, it's gonna come back to me. Lack of attending healthcare appointments, and I believe the other one was just simply advocacy. So there have been a few disparities mentioned by today's panel, such as advocacy and lack of attending routine healthcare appointments. Are there any other disparities that may impact maternal, mothers? And if so, what do those disparities look like?
Start.
The other is the built-in structural biases to minorities in the United States. That's why you see such a big discrepancy in the United States versus the UK. The UK has multiple minority groups in the UK, but their maternal mortality and neonatal mortality is nothing compared to ours. There's more advocacy for those particular groups of people, and there's more programs, there's more supportive community programs that is accepted nationally. I just picked the UK because it's the closest model to the multitude of people similar to the United States. The UK has the National Health Services, where their medical care is provided, so people don't have to worry about that, and they have certain standards that even patients have to adhere to, and everybody kind of works jointly together in that national system, and that's what we don't have in the United States. But I see it every day. I see minority women, African American women, Hispanic women, their concerns are not taken seriously. They're for a multitude of reasons. I think there's cultural differences in presenting your fears and concerns and questions that's in our institution that is an Anglo-Saxon institution that people don't know how to relate to, so therefore they don't know how to answer it or dive into those issues. If you're Hispanic and you're first generation, you may not have the command of the language, so people don't take time to either find an interpreter for you or bring the input of your family, because it's more of a family input and question, and people are concerned because they look to their family members for input, and so they don't bring the family into it also. So there is a lot of things that make it very difficult for minorities in the United States. The problem is it's a double-edged sword, because we know those disparities exist somehow, that we're going to be accepted, looked after, and taken seriously. Some minorities don't come to the doctor, don't bring all their concerns to their doctor, and they start to look at doctors as adversaries instead of someone that's there to help. There are bad players out there, but for the most part, there's people that really want to help and really want to help you. But doctors are human, so not everybody's personality is going to click. It's almost like, going out on a date, see who you click with the best. And so you find that person that has the similar experience than you, but also someone who is not afraid to speak to your bad tendencies, and to take that that we're trying to help and not just talk bad about some things. Sometimes we have to have those hard conversations, and we all have our bad habits that we don't want even our loved ones to bring up, but we need that in order to be healthy. But that is a deeper issue, but it's even deeper for women in particular, because in our healthcare system in the United States, what makes it bad is a lot of things for women. We should be the healthiest in our community. We usually have better lifestyles and make better choices, but we're not, because even when we go to the emergency room with heart conditions, they tell us it's anxiety, or they tell us that we're overreacting, and don't listen. We're not heard. We're not seen. And therefore, sometimes people don't go because if they feel like they're going to be invisible, why go?
Dr. Spraggan, what is foot and mouth disease?
It's a scourge. It is hand, foot, and mouth disease is most commonly caused by a virus called Coxsackie, but there are other viruses in that family group. It is miserable. That's why I called it a scourge. It's just miserable. But usually marked by blisters and rash on their hands and feet, sometimes on their bottom. Sometimes it can be more widespread depending on how, what kind of skin they have, and usually some sores or blisters in their mouths. I won't say that it's benign, but it will run its course in about a week and a half. But it is miserable. It is. And actually going around right now. Yes, ma'am. Again, yes. But it's something that's treatable and that usually has no long-term effects or anything, but it's just miserable. It is.
But it's not just for kids. Please wash your hands because
Yes.
in gynecology, you can get it in your vagina and it's not good.
And if you've not ever had it, when I first started practice, my medical assistant got it because apparently she never had it as a child, and it was terrible. It was terrible. She was down for probably a week, and I think she had to get IV fluids. So the most important thing with hand, foot, and mouth is that you push the fluids and try to keep them as comfortable as you can. But the fluids are the most important thing because they can get dehydrated from not wanting to eat or drink because of the virus.
I would like to ask the neonatologist, how in the world can someone be made aware of those programs? I'm really surprised at them. If the kids or children are critically ill, how do you know to ask that? Is it explained to them, or who would know that those services are available? The ones you were speaking of, Dr. Spencer, the ones where if the child is ill, you can ask for the different conferences and also that their plan as an outpatient can be outlined. I think that's excellent, but I could see a lot of people missing that. And if it's not offered, if it's not routine, who knows about it, or how is it offered? Both of you.
Dr. Holt and I were just asking about that. That's why we feel so passionate about coming and telling people about it, because unfortunately, if you don't have an inside of purview, sometimes you just don't know. And I think that lack of knowledge sometimes also precludes us from being able to optimize our care because we just don't know. So that's why I appreciate us being able to disseminate this information. But I would say the best resource is our social workers are really, really good at being able to help parents navigate a lot of aspects of the NICU. So that would be a good resource to talk to. And then the doctor that's taking care of your team should be able to let you know some of those things. But I have seen it where sometimes if a parent just doesn't know, they just don't know. And sometimes they'll ask for it because they heard another parent say, oh, I had a care conference. So then they'll request it. But yes, unfortunately, the information is not widely disseminated. So people who haven't had a NICU experience prior to their baby being admitted might not be aware that there are all those resources that they could ask for so that they could feel a little bit more grounded in the NICU.
I wanted to kind of piggyback back on what Dr. Hubbard said. When you said parents are allowed during rounds, I never knew when neonatologists or when they were making rounds, it was never a time where the parents could come in. I can see a sign on the door at Eastridge that says these times are blocked out because the physicians are making rounds. So are you all allowing parents to come in when you're doing rounds?
Yes, they are allowed to be present during rounds, and actually I prefer it because they can be updated while you're rounding, so it's kind of one less extra thing that you have to do during the day. And then if they're aware of what's going on with their baby, it's easier to update because they know they've been present, they know what's going on, and then with time, they kind of know what questions to ask because they usually our babies, not all babies, are in the NICU. They could be there for several weeks, months, depending on if they're born extremely early or if they're very sick. So we prefer for parents to be present on rounds because, one, they learn what's going on with their baby, and it makes it easier to also build a relationship with the parents, so that they kind of build a trust between us and them, and I think it just makes it a better experience for the baby because they know what's going on, and we have at least a relationship. So it makes it easier to communicate, especially when things aren't going well sometimes, because not all, it's a NICU, babies are sick, so it's not always a good conversation, but at least if there's some trust there, it makes it a bit easier to care for their baby.
I'm glad you asked that, Dr. Shaw. Actually, a lot of NICUs now are going to something called family-centered rounds. So it tries to make the parent really see that you're a valued member of the care team. So we invite parents to come. I usually tell parents when I do prenatal consults that the NICU is like we speak a different language, so the two of us understand our language, but it's a very foreign language to every parent. And it's such a stressful situation when you come into the NICU that everything can come at you like 100 miles a minute, you know? And so I tell them, if there's something that's stated to you that's unclear, it's not our intention, and we're asking you to ask us to restate it until you understand clearly. So in our NICU especially, parents are definitely welcome. We very much appreciate having parents there during rounds. Ours usually occurs between 10 and 12 a.m., and we do orient parents to that. So every parent is aware that they're welcome during rounds and the time that rounds occur. And the only time for us when our unit closes down is, we try to say 24/7, except 6:30 to 7:30 in the morning and the evening when the nurses are actually handing off. And that's just an effort to try to keep the patient information confidential, but other than that, we welcome parents at the bedside for as much as they can be.
Wanted to give, this is not necessarily related to the NICU, but I think even with like education, if you're unfamiliar with hospital, how ICUs work in general, like for example, I had a friend whose mother was in the ICU, adult ICU, and she was having difficult getting updates on how her mom was doing. And I know I work with babies, but I was like, she said the clerk said that she couldn't connect her to the nurse. I was like, asked to speak to the charge nurse but she wouldn't know that because she hadn't experienced that, because I said the clerk probably doesn't mean any ill harm, but they have like a kind of a script that what they're allowed to give and what they're not allowed to give. So if you have that difficulty, you're not being rude, you're just trying to get information, ask to speak with the charge nurse because they'll be able to connect you to who you need to talk to, but you may not know that, because if you've never experienced that, you wouldn't know that. I think our social workers are good with helping parents like navigate that. If parents are having difficulty, ask to speak to somebody. You're not being difficult. You're trying to get information about your loved one. So there's nothing wrong with that.
Yeah, I just had a quick question for actually probably the full panel here. Something that I kind of ran into in my OB-GYN rotation in Columbus, Georgia, we actually encountered a couple of patients who my, I guess OB-GYN had to kind of like protect them against themselves, where they're having like multiple children, like 9, 10 children, where the next pregnancy could either, put them in danger, but also even put the child's life in danger by having to go to the NICU and things like that. So I'm wondering, like, when you guys encounter situations like this, when you have these patients and they're in low socioeconomic status, how do you navigate, trying to really help them understand kind of the dangers of continuing this pattern of pregnancies?
Well, that's why I said choose your doctor like you would choose a partner, that's someone that you can talk to. Usually I try to tell people, not in medical terms, of how it's going to impact their health. Not one person can tell someone to either have no children or have 10 children. Not too long in our recent past, people had 10 and 11 children, but things were a little bit different. What I try to tell them or encourage them, if you want a big family, then let's make sure that we wait at least 12 months. At the very minimum, give me 12 months to allow your body to recuperate, allow you to have time to bond with the baby, allow everybody else to fall in line like little ducks in a row. That gives them a little image. They know what their day-to-day life is going to be. It's easier for you, get one out of Pampers, so you appeal to their sensibilities on what day-to-day life is going to look like, and not just tell them you shouldn't be having these babies back to back to back to back. You need to talk to them on how it's going to affect their everyday life. And if they want it, say, I'm here to support you. But remember, we don't want our baby to go to the NICU. We want our baby to go home with us. We don't, you don't want problems. You don't want to be on bed rest. Remember, you were on bed rest last time and you didn't like that. Yeah, I remember that. So it's also being, when you choose a physician, not to doctor shop to, someone that you can have a history and a relationship with. But you also have to bring that, it's that personality. And everybody looks for something different. But as far as my relationship with the patient, it's very informal and it's very intimate as far as remembering something from their last pregnancy or remembering something from 2 years ago when they came to see me and relating it back to that. Because for the most part, most people, believe it or not, have plenty common sense and they want the best for them. Themselves and their family. So if you give a little bit, you don't necessarily have to say that you can't have 10 children, but if you're going to have 10 children, let's wait, 12 months, let's wait a year and a half before we have our next one so everybody in the family can be healthy.
I think we're going to have to address the social determinants of health. I'm big on that. Because if you don't have transportation, they can have parent visiting hours from what you can't get there and can't get off your job and these kind of things. And I think that's a lot of it, and poverty. In the 80s, the term was crack baby. In the 90s, and I watched a lot of them come of age. You got these new drugs now, and a lot of these kids, I'm a pastor, stop getting high. Is the bottom line, period, when you're pregnant. With the new drugs, how is that affecting, especially, coming into the NICU, where's the drug use? And you have people out there who are still using heavy, fentanyl is the new thing that I hear about. And just people using drugs. Where's the drug use and how is that affecting childbirth and that kind of thing now?
That was actually, I'm going to piggyback on Reverend Wilson. That was actually one of the questions that was live streamed in, and the panel can talk about that too. And it says, what is neonatal abstinence syndrome? So that in conjunction with the question that Reverend Wilson asked.
So there are a couple of terms. There's neonatal abstinence syndrome, and now there's neonatal opiate withdrawal syndrome, which kind of references your use of the increased risk of opioids nationally, which could be like morphine, fentanyl, over-the-counter prescription pain medication. Neonatal abstinence syndrome is more kind of an umbrella, so that could be withdrawal from any illicit and some also prescription, so amphetamines, tobacco, don't really see, and methamphetamines. It can include opiates. And then now syndrome is particularly from opiates. And in our NICU, we do have babies that are admitted for that reason. For withdrawal, so not every baby, but they can have withdrawal syndrome symptoms that are severe enough where it interferes with their ability to be a baby. So a baby needs to eat, sleep, and be able to be consoled. Those are like the main things. And if their withdrawal is so severe that they can't be an infant, then they may require ICU admission so they can actually be treated with medication in our unit, morphine and some other medications if that is not enough. And it's not that we're not giving them extra medication. It was something they were already exposed to in the as I referenced, opiates. And we don't necessarily see what the long-term effects are, but there are increased risk of like development delays, school difficulties, ADHD, attention deficit disorder. So that is a problem. One thing that one of our NICUs is trying to do, there are a couple options to be treated with medication, but we also try to use like non-medication related interventions, such as feeding them on demand, like letting them eat, not waking them up when they're sleeping, keeping a quiet environment. So we try to do things that don't involve medicine first, but some babies do require medicine. And one thing is trying to, that our units are trying to do is to bring the mother in as a partner instead of making her feel guilty or ashamed if she is like trying to change, trying to do what's right for her baby. So instead of putting blame or stigmatizing her or, judging her, we try to make her a partner, because babies who have like a parent they can visit often usually don't need to be in the NICU for as long, because they have somebody that's there all the time to console them, to feed them, to be there. Because our nurses, they try to do those things, but they have other babies, so they can't always sit there and hold a baby. We also have cuddlers that come to the unit to help with that. So there are things that we do try to do, but we recognize that it is a problem, not just in Tennessee, but nationwide. I think that's why there have been things that track like how doctors prescribe pain medication to try to prevent the problem for the opiate dependence disorder in people and mothers, so it doesn't come to where it affects the babies.
One thing that I would say, speaking to that, is the root of the problem is undiagnosed or untreated mental health issues. People try to use, whether it's marijuana, other opioids, to escape from whatever that they're going through. In the minority community, it's still stigmatized. That's across any minority community for getting help with mental health issues. And there's a lot of mistrust. This country has a lot of history on mistrust, but there's depression, there's bipolar disorder, there's things that should be treated with proper medications, so people don't feel like they have to escape to other drugs to help them with their attention, to help them with their anxiety, and even their hopelessness. So if people can be encouraged in their family to seek help for any mental health issues and actually take the medicine and go and actually talk to your counselor. Please take the medicine and talk to the counselor, because this Delta 8, you don't need to do it. Just please don't. You don't see what I see on the other side when we're trying to put you to sleep for a surgery. It is not good for you. It's synthetic and it's worse than cannabis. And the other thing that people don't realize, it's marijuana, it's healthier, it's natural. Native Americans smoked it, it's okay. But you don't realize the drug dealer is not with the Better Business Bureau. You don't know that you're getting just cannabis grown in the backyard with sunlight and organic water, alkaline water. What you're getting is some LSD in there, some fentanyl, and tobacco. You're getting dirty weed so that you can get addicted and come back for more. So you're going to come to labor and delivery. We're going to check your urine, and you're going to have a positive drug test, and you're like, I didn't do anything. I just did it for my anxiety or my nausea because I heard that it was good in cancer patients. That's what ends up happening. Then you have social work get involved, and then you're still dealing with the Better Business Bureau drug dealer down the street. So it's not necessarily good stuff that you're getting there, and Chattanooga is known for that. So even the Delta 8, please stop and just take your Prozac, take your Zoloft, talk to your counselor, work through the issues, so that you can be healthier, not just for yourself but for your family.
And I would still add, the number one thing is still to be honest with your provider. We are not here, like she said, to judge. Even with that urine drug screen that you get when you come into the hospital, and that's helpful for us to know, so we can let our other team know if we do see something going on with the baby. So the biggest thing is still to encourage everyone to be honest about what they're doing, because that's also an avenue to get help during pregnancy if you're dealing with, with drug addiction. There are ways and there are people that can help you with that, and we can help coordinate those things. But that would be my number one thing, is regardless of what you're doing, to be honest about it with your primary care, with your OB, especially if you're pregnant. And then also potentially, with your kids' doctors. I mean, because they could have been exposed to something at some point in time.
I do want to jump in and say that marijuana is not safe, and it is not safe for developing brains. Your brain does not completely develop till you're about 25. And so, I know I have some parents who won't confront their kids about their marijuana use. And now, they've gotten smarter and they vape it, so you don't really have the smell where you know that they're doing it. But it makes anxiety worse. I see that every day. It makes it worse, that I can still be treating them with prescription medicines and they're still smoking, and it's counterproductive. And so it does not help anxiety, and it can be, in a way, addictive if you have chronic use. And so please, I'm like, to stay away, because you don't know what you're getting. Even if you have a trusted weed man, he probably doesn't know what's in that stuff, and you don't know either. And so I would just say a hard pass, no.
I just also want to add another thing. We've seen a few babies, and it's not just like where's prescription, but there's things that you can buy, I guess, legally. We've had a few mothers who use kratom for nausea. You can buy it's a tea. You can buy it. It's not necessarily illegal, but we see babies that have withdrawal syndrome. It's kind of same as if mom was on overusing or misusing opiates and prescription painkillers. So just, I guess, be careful of what you use during pregnancy. Not everything that's natural in a tea is necessarily.
Hey, remember, arsenic is natural, but you don't take arsenic, right? It's a naturally occurring, but it's not good for you.
Hello. Okay. Thank you, ladies, so much for your time and sharing all the knowledge. The question that I have is, earlier you made a comparison of the healthcare system or lack of here in the United States compared to UK. With that idea of equitable healthcare, what could that look like here locally in Chattanooga? So basically, what would be your ideal community-based program here in Chattanooga to address the concerns of, or how we can support these families?
My wish list is all women to get out and vote for themselves and for their interests. I know women are 52% of the United States of America, and all our legislation, everybody that you see up here, everybody looks at doctors as, deep pockets or all this, but women and people that treat women and children, we don't have the deep pockets. We don't get reimbursed, and most of our healthcare resources in the United States do not go to caring for the women and children in the United States. That's not where the money goes. So we need people more engaged in actually where your dollars, where your healthcare dollars are going, where your focus is in your hospital. It's not necessarily on orthopedic unit. I'm not saying anything bad about orthopedics, but I am kind of biased, so I'm just going to claim it. But it has been shown, study after study after study, that if you make sure that you invest in mothers and children, you have a more productive and affluent society. Overall, from the bottom to the top, everyone does better. But when you have a society that does not focus on women and children, you start to see the splintering of the society, and that's what we have right now. There's not one way to fix that other than if I could get all my women to take charge and engage and demand that your health care, your ability to be seen, to be heard, not to be invisible in our medical society is brought to the forefront, then it's going to be a better day. It's going to be a better day standing up at the local level to the state level to the national level, and not just getting what is given to us, but take what is rightfully ours again.
I don't know. One more question.
Okay. So my question is, well, first of all, I'm very happy to see all these ladies up here and who look like me. And so my question is for you doctors who are in the profession, and you might, let's say, okay, so let me back up. So let's just say I'm a mother, okay? So I want to come to a hospital, or I want to find someone who looks like me. And what if I don't? So let's say I don't find someone who looks like me, who might not advocate for me. Yes, it's time. I might not be able to advocate for myself. I might not know what questions to ask. My question is, what is done when there's doctors who are not minorities? What is the education for those doctors in terms of taking care of people who are minorities? Is there a lot of education on that side? You know, like what medications work best for us? I know that there are medications that work better for us than, you know, other groups, or well, non-minority groups. And so I just wanted to know on that part, what is the education being done? Is there a lot of education in that area for doctors who don't look like us?
There was, I don't think that there's enough, and that goes back even just to what education we get on cultural competency and social determinants of health, just across the board in training, in medical school, and then in training. I think the first thing to do is to attend things like this and to figure out who your community is and who is within that community. And I think luckily, and this is from growing up here in Chattanooga, I've been here since I was 5 years old, so over 25 years. I think Chattanooga overall does a really, really good job of our community physicians that look like each other, and having events like this. And so I think the first thing to do is to go in that community and ask other people and say, who are the doctors that look like me, that are taking care of people that look like me and that do a really good job. And I think across the board they do, not just with OB and in peds, but in, you know, internal medicine and family medicine and different things like that. And there are, so yeah, that's what I would start with, that for sure.
Raising awareness is really important. So in order for us to address the issue, it has to be pushed to all the platforms out there to say this is an issue. So the fact that you see lots of people now talking about the fact that we are not going to stand for the maternal mortality for Black women to be this discrepant from others, and the infant mortality to be so high. So just raising awareness to it has caused people to put more resources towards it, for people to make those wish plans that you said come to life. And one of the things that the medical schools have been pushed to do, which a lot of us can sit here and tell you we didn't get much training with regards to the health inequities that are present, they are putting more pressure on medical schools to start teaching the medical students about it. So I think that's where it will start. They're recognizing that we have a void that needs to be filled to make sure that we are teaching the minority physicians how to care for the minorities in the community appropriately. So that's something that they're trying, because there's only 5% of the physicians nationally are Black, right? So the likelihood that you'll have a non-Black physician is high. And so for us to make sure that we can make sure other groups know how to care for us is of paramount importance for us as well. And I do want people to be assured that there are non-Black physicians who have hearts of gold that want to take good care of you as a patient. Sometimes what happens is there are biases, unconscious biases that affect people, and sometimes if we try to address it head on, you can get the conversation kind of shut down. So we're all learning how to navigate that, but we've experienced interacting with doctors who are non-Black, who are passionate about caring for patients, and will also be those that assist us in moving things forward to address the inequity that we're experiencing. Because I can tell you, as a Black woman, I walk into the hospital and I'm a Black woman. Nobody sees me as a Black doctor if I'm coming in as a patient. So the same concerns that you would have, I have as well. So I want it addressed as passionately as you want it addressed, because the risk for other Black mothers would be the risk for me when I walk in. So that's something that we'll be championing for sure. So I appreciate that question. I was just gonna circle back to this wish list, because if you ask me to wish, I got wishes, okay? So I would say voting is gonna be really important, because even though there's been legislation to promote anti-abortion laws, we haven't seen a strong legislation to get mothers time off from work so they can take care of said baby once the baby is born, right? So that will be something that's important, because then your baby, you can comfortably sit and take care of your baby in the NICU or wherever your baby is, and not have to worry about how am I going to afford to sit here. Because a lot of times people can't not work because they have to pay bills, they have things to do. And that's one thing that the UK system does a lot better than us. They're allowing moms to be off from work, even dads off from work, is a long time. So if their baby's in the NICU, anyway, maternity leave, sorry, slipped my mind, guys. Okay, their maternity and paternity leave actually starts after they leave the NICU. That's not happening for a lot of people, so that's something I would want to address. I went to a conference recently as well where it was an innovative conference, so they were talking about if we could imagine things, what we would imagine, and somebody pitched having Teslas drive people to their doctor's appointments. I'm all for that. Come on now, get the Tesla, let's drive people to their doctor's appointments. Because you did say that transportation is an issue, which it is an issue, and so, if we had a system, like the Uber system for taking your patient to their doctor's appointments, we can drive them to their doctor's appointments, and that would be extremely helpful. But in the meantime, until we got the Teslas, I did want you to know that social workers can help the parents get transportation. That's easy work. They can really help them if the parents just bring it to our attention that that is an issue.
I'd like to thank you all for your presentation tonight. Today I gave this flyer out to a lady, and she said, there are 6 Black female physicians in Chattanooga. She didn't realize it. So one of the things that happened to us, we have to begin to get the message out that we are here. Because many times in the community, when you're at Erlanger, when you're at one of the hospitals, you don't necessarily associate with the community. And so what happened to us, we have to become more active with respect to talking about one another and being champions for one another, to be encouragers for one another, to be able to come to a conference like this in which we can share information that most people in the community do not really know. And I thank you all for your frank information. One of the questions that I want to ask is that C-sections versus vaginal deliveries. Do the NICU unit see a difference in the number of babies coming to the NICU unit versus C-section versus vaginal deliveries? Or how is the first year of life of a baby who is delivered vaginally versus one who has a C-section?
Well, I'll defer to the obstetricians just to talk about the indications first, and then we just handle the baby after. And one thing about us, we have a really good rapport with the obstetricians. So when they tell us a baby needs to go to C-section, we know it's go time to go to C-section. And the one thing, I've had a lot of friends, when they usually will have a plan for what they would want for their delivery. And if they usually come in with a plan, it's a strong plan, which usually only has vaginal delivery in mind. And because we see some of when things don't go well, I could never advise someone not to follow their OB's instructions when it's recommendation for going towards C-section. The one thing I've told my friends, this means it's people that I love dearly, is if you do want a vaginal delivery, you need to make sure you and your OB have a relationship to when they tell you we have to go to C-section, you trust them that they wouldn't take you to C-section if they didn't need to. From our experience, we usually see that if the C-section, usually if you come into the hospital and you were planning to have a vaginal delivery and the OB now tells you that you need a C-section, it's usually because something either happened with your baby that's an emergency. So the baby's not tolerating the labor, and so that could mean that the heart rate is dropping during the labor, which it shouldn't be dropping below the normal ranges, and you guys can go over the ranges that you expect, but it shouldn't be dropping below the normal ranges. So a deceleration, that's concerning. And for us, if we heard that there was what we call a bradycardia, meaning the heart rate dropped and stayed low for a while, we understand that that means the baby's in distress. And a baby in distress could mean that it could come out and need a lot of resuscitation where otherwise it wouldn't. And so in those cases, a C-section for the baby can be a life-saving situation. We got a lot of parents who come in and say, well, the whole pregnancy went well, but the baby's in the ICU for these complications. But if the pregnancy has to go well and the labor and delivery has to go well for the baby to do well. So like I said, the biggest thing I would usually say is make sure you have an obstetrician that you trust so that when you hear them say it's time to go to C-section, you recognize that they would not tell you that otherwise, because C-section does have its risks. And so, yes, but if it's the difference between your baby having a neurologic deficit that's not reversible versus a baby that comes out and looks great, we love to hear babies cry. I don't know how parents feel about that, but for us, we love to hear a baby cry because that means it's a well baby, the baby's doing good. But if a baby is down for a long time, they can come out very depressed, meaning not breathing on their own, and that's why we're highly trained to be able to take care of those kind of babies when they come out and they're basically not breathing, and we have to resuscitate them so that they could survive. Did you want to talk about HIE or hypoxic ischemic encephalopathy? The one issue that they can have is something called hypoxic ischemic encephalopathy. HIE is how you will hear us reference it, and that is an issue when the baby's brain was not getting enough blood flow at some point during the pregnancy, and it could be distant before the delivery, but at some point it wasn't getting enough blood flow, and it can cause the baby to have neurologic deficits that are very long term. We found a treatment for it, but it doesn't fix the irreversible damage that occurs. And many of us don't discuss it much, but there are babies who are otherwise well in their mom's uterus that die as a result of labors that did not go well. So unlike some of the other doctors, I'm actually not opposed to Dr. Google. You can let's chat about what Dr. Google told you. That's how I like it. But in the moment when a doctor is telling you it's C-section time, that is not the time for Dr. Google, because seconds is brain cells for your baby, and we can't reverse damage that's already done to your child. And even though sometimes you wonder, are we all on the same page? For the most part, people want good outcomes for the patient they're taking care of. So the goals are the same, even though it seems like the method of getting there might be different.
My philosophy is healthy mom, healthy baby. How you get there really doesn't matter in the end. It's a double-edged sword. People right now, for some reason, we have selective memory loss. Historically, childbirth is the most dangerous time in a woman's life. Historically, I mean, let's just go back to the 80s, go through the graveyards right now and look at the women who died in the 80s from vaginal deliveries and complications from it. It is miraculous that that we have the good outcomes that we do have. But C-sections are more common, but they're also more foreign to people, and don't feel as in control. Sometimes C-sections are necessary. The babies do well, develop normally after a C-section versus a vaginal delivery. Even though it's a Houdini experience seeing a baby come out of the vagina, it's nothing magical whether your baby came out the vagina or came out through the sunroof, as I say, a C-section. Your baby's going to do fine. There's nothing about squeezing the baby through the vagina that's going to set your baby up for Harvard versus community college. That's not the case. That's not the case at all. But also sometimes to force something to happen, because we have technology that can save moms from damage to their pelvic floor. You may not see it now, but maybe that 10.5-pound baby shouldn't have come out your vagina. Maybe you could force it through. But later on life, you'll have incontinence, pelvic floor dysfunction, pain with sexual intercourse. There's a lot of other things that are not said that are also said on, Facebook makes you believe that if you didn't have a baby vaginally, you're not woman enough. You had a baby grow inside of you for a year. So it doesn't matter which way, as long as you get a healthy mom and healthy baby, that's all that matters. But you do not want to just have a C-section because you're tired of pregnancy. Is 40 weeks. That's 10 months. It's not 9 months, it's 10 months. And it's awful at the end. It's uncomfortable. There's very few people that say it was a magical experience. Usually about the time you get to 34 weeks, your back hurts, you're peeing all the time, you're swollen, you're tired, you can't hardly move, you're miserable, you got this thing inside of you that's kicking your liver to smithereens. And it's horrible, and you look at your doctor and you say, the very beginning, the first visit, I don't want any interventions, I want this all naturally, and I'm gonna wait till 42 weeks to have my baby. And I just smile and say, okay. And then by 32, 34 weeks, you're like, so when can I have this baby? So the issue is, and what our neonatologists want us to do, that you need to make it at least to 39 weeks if we can, if there's no other reason why you shouldn't deliver. For developmentally, the baby needs to be inside mom for reasons to develop properly. If the inside is hostile, then outside is better. But if inside is always better than outside. So wait for your 39 weeks at the very minimum. But if it's your first baby, unfortunately, it's a hazing period. You're going to have to push through. And sometimes it's 40 weeks, sometimes it's 41 weeks. I don't get down with 42 or 43 weeks. That gets me too nervous. But sometimes it's 41 weeks, and then you're more likely to have a normal vaginal delivery. But it's always finding that right medium when it's time and when it's not time. But for the most part, most OBGYNs don't want to have no one wants to see a bad outcome with mom or baby. So we're going to do the best we can to get the baby out intact so we can go to all the T-ball games, all the kindergarten graduations and all of that. That's what we're all hoping for. We're not just trying to get the baby out just because.
And if you ever have a question, just ask. Whether you're asking your OB when they come in to see you, ask the nurses, ask the charge nurse. All of those people on labor and delivery have experience and can give you some sort of guidance. And if people are coming in and out, and you're hearing things about, oh, the heart rate, just say, hey, can you tell me what's going on? I think that's one of the most important things to get from today is again, going back to advocating for yourself and advocating for what you want, but also having those discussions with your doctor throughout the entire pregnancy. How you really want to deliver shouldn't be something that you wait until you're in the hospital to discuss with your doctor. Have those conversations, but always ask questions. And if you don't understand the way that somebody's explaining it to you, ask them to explain it again. And if they can't explain it, ask them to get a friend to come and explain it. Because it's your health and it's your life. And this is not a dictatorship. This is a symbiotic relationship that you should have between all of your providers for your health.
We've had some great conversation, and I just applaud and thank everybody who's up here for spending your time with us. I just wanted to say that the voice back there, Dr. Cornelius Mance, is the president of our medical society, the Mountain City Medical Society, that's here in Chattanooga. We appreciate you having us.
Well, thank you. Big round of applause. Thank you so much. It's really been uplifting, especially to see young African-American ladies providing this information. We thank you so much because it's been a wealth of good information. We thank our online audience. I almost said radio audience. We thank our online audience for being with us. We also thank CHI Memorial for being a sponsor, Bessie Smith Cultural Center for being a sponsor, and the Mountain City Medical Society for being a sponsor. We look forward to doing this again. I think our next series will be on August 24th, 6 p.m., and we look forward to having an even larger audience. I'd like to take time out to also thank Southern Adventist for being online with the class. So you got some people listening, okay? And we also would like to just ensure that we ask this question, the last question. Are the OB/GYN pediatricians accepting new patients? All right, well, we need to get that information so we can put it online, make sure that we let people know that you all are accepting new patients. I know the NIC unit is not looking for new patients, but by the same token, we would like to share that information. Thank you once again for being with us. Hope to see you in August for our next adventure going down the line. I don't know what the next series will be about, but we'll get that information out to you in a fairly decent time so we can have a larger. Tell somebody about this, okay? Make sure you do, because it's good information, and we need this. Thank you once again. See ya.